This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2019, all rights reserved. My name is Dean Hess. I'm a respiratory therapist and managing editor of Respiratory Care. I welcome you to the AARC Summer Mechanical Ventilation Series and today's presentation, VAE versus VAP, Different by Design.
As a leading manufacturer of critical care ventilation solutions, Hamilton Medical is proud to sponsor the following webcast about ventilator-associated events in adult critical care ventilation. The ventilators from Hamilton Medical ventilate all your patients, from the neonate to the adult, in the intensive care unit, during MRI procedures, and in all transport situations inside and outside the hospital. Each device is equipped with the same standardized user interface and features the same intelligent ventilation technologies. To avoid ventilator-associated events, it is essential to comply with the applicable guidelines and recommendations. Hamilton Medical's intelligent ventilation technologies support clinicians at the bedside by applying lung protective strategies that adhere to current recommendations. The Hamilton Medical Ventilation Geeks at our AARC Congress 2019 Booth 527 would love to tell you more about it. We're looking forward to seeing you in New Orleans.
Upon completion of this AARC webcast, participants will be able to delineate the limitations of VAP as a metric for quality improvement, describe the CDC's rationale for creating VAE definitions, and outline strategies to prevent VAEs. I am pleased to welcome Dr. Michael Klompas. Dr. Klompas is an infectious disease physician, professor of population medicine at the Harvard Medical School, and hospital epidemiologist at Brigham and Women's Hospital in Boston, Massachusetts. Dr. Klompas was a leader in the 2011 CDC Ventilator-Associated Pneumonia Surveillance Definition Working Group and has published extensively on ventilator-associated events and ventilator-associated pneumonia. Dr. Klompas discloses that he has received grant funding from the Centers for Disease Control and Prevention and the Massachusetts Department of Health and royalties from UpToDate. I disclose relationships with Daedalus Enterprises, Philips Respironics, Ventec Life Systems, Jones & Bartlett, McGraw-Hill, and UpToDate. Brand names of products and or medications may be mentioned only as examples of technology. Mike, welcome to the program.
Thanks very much, Dean, and thanks very much to the organizers for this opportunity to be able to chat with you today. I was asked to give a rehash and expansion of the talk that I gave at the Congress this past year. So parts of this will be familiar, but parts of this might be new. So I'm very excited. Let's get going. Okay, let's get going. So our objectives today are to discuss the following three issues. Number one, why did CDC replace their traditional VAP definitions with VAE? And I'll discuss the rationale behind that, and that has to do with the limitations of traditional VAP diagnosis and the implications that the limitations of the traditional definition has for both prevention and surveillance. I'll ask the question of how can we optimize surveillance for VAEs, including reference to CDC's online VAE calculator and the increasing number of hospitals now that have automated VAE surveillance systems, and then switch our attention to discussion of prevention of VAEs. Next slide. So why did CDC replace their long-standing traditional VAP definition of VAE? As you know, for many years, ventilator-associated pneumonia was the metric par excellence for tracking safety, for quality of care, for ventilated patients. So after literally decades of using that as their primary metric, why did they let go of that, and why did they switch to VAE instead? Next slide. The fundamental challenge, as I see it, is that our capacity as clinicians to diagnose ventilator-associated pneumonia simply is limited and imperfect. The problem is that there are many things that can go wrong for a patient on a ventilator that all kind of look the same. So if you think about the cardinal signs that we look at to diagnose a pneumonia in a ventilated patient, so radiographic capacities, fever, abnormal white blood cell count, impaired oxygenation, increased secretions, each of these clinical signs is neither sensitive nor specific. So you think to yourself for a moment of all the different things that can cause radiographic capacities, from fluid to atelectasis to pneumonia itself to contusion to underlying lung disease, etc. It has a very broad range of differential diagnosis. And somebody who's simply looking at the chest images alone cannot reliably tell which is which. And so too for each of those other cardinal signs of pneumonia, for the fever, the leukocytosis, impaired oxygenation. There are lots and lots of different things that we can all rhyme off that can cause those findings in addition to pneumonia itself. That's, I think, the core problem, is that our capacity to diagnose this condition with confidence, with certainty, is inherently limited. Now, the best demonstration of this is, of course, the chest X-ray. Next slide, please. So here is a film taken from one of the patients in my hospital, chosen more or less at random, but didn't have to look very far to find a representative picture. And at first blush, you can certainly see that this is not a normal film. There's something wrong with this patient. But it belies, I think, many of the challenges that we all face in trying to interpret radiography. Number one, this is a technically limited film, right? It's underexposed, underpenetrated. There are overlying tubes and lines over there. The patient's in a bad position. The patient has an incomplete inspiration. But those are not exceptions. Of course, that's very much the norm as to what we see when we try to take pictures on this very challenging patient population. And so, again, while we can all see the abnormalities inside this film over there, the opacities in the lower lung fields on both sides of the body, who can say with confidence what is actually causing those opacities? Is it pneumonia? Is it fluid? Is it atelectasis? Is it ARDS? Is it something else altogether? Or, more likely than any of the above, is it a combination of some of these things, some atelectasis plus some fluid and maybe pneumonia hidden somewhere in the background? The problem is, of course, that none of us can tell. And that's a fundamental problem if VAP is going to be used as a quality metric to opine on whether your hospital is doing a good job or not. If we can't agree on who has the outcome or not, how can we compare one hospital's findings to another's? And how can we use it to say that you're doing a good job and you're not doing such a good job? Now, when I show the slide to non-clinicians, I think their first thought is, well, hang on a second. You employ a cadre of professionals to interpret these radiographs for you, right? Radiologists. What do they say? So if you look at the next slide, here is an extract from the radiographic report for the images that we just took a look at. Diffuse patchy airspace disease, right greater than left, with obliteration of both hemidiaphragms. Opacity is possibly slightly increased since yesterday, accounting for changes in patient position and inspiration. This could represent atelectasis, pneumonia, or effusion. In other words, the radiologists themselves are quite honest and quite frank that they too can't tell exactly what this image represents. Now, you've got to remember that the people who actually count up the VAP rates for your hospital are the infection preventionists, many of whom are doing that surveillance at arm's length. They're doing it through the computer alone. They're not actually evaluating the patient themselves or even looking at the radiographs themselves. They are reading the report in order to make that determination. Now, you could imagine how different infection preventionists looking at the same report could come to different conclusions. Some might say, well, it says the word pneumonia, so this counts. Others might say, but it says it could be other stuff. This does not count. And of course, different infection preventionists could be quite reasonable in taking either one of those positions. So again, we're left with this problem of not knowing at the end of the day if the results called by one person or one hospital are comparable to what another hospital or another person might find. Next slide. The truth is that if you take a population of patients that at first blush appear to have ventilator-associated pneumonia and you intensively investigate them, what you'll often find is that there are lots of different things that can cause the constellation of clinical signs that look like pneumonia. So, for example, I've taken data here from 2 studies that analyzed patients who had fever and infiltrates. Again, at first blush, the population of patients in whom you might be worried about a ventilator-associated pneumonia. And on intensive investigation through additional imaging or diagnostic specimens or, in some cases, even autopsy, they found that fever and infiltrates in this population could be attributable to ARDS or blood clots or hemorrhage or infarction, fibrosis, carcinoma, lymphoma, contusion, so on and so forth. Even more striking than the breadth of different things that can cause pneumonia is that more often than not, there are two or more things going on at the same time. Again, these are complicated patients. There's lots of stuff going on at the same time. You know that as well as I do. And so, for example, a patient might have two things going on at the same time that individually look nothing like a pneumonia, but if they're present at the same time, might give the net clinical impression of a pneumonia. So, for example, a patient might have increased secretions because of tracheobronchitis, or they might have a fever due to a central line-associated bloodstream infection, or a urinary tract infection, or a drug reaction. Now, again, individually, none of us will be fooled. None of us is going to label that as pneumonia. But what if that exact same patient at the exact same time also has some pulmonary edema, or some atelectasis, or it's a trauma patient with contusion, or there's some underlying fibrotic lung disease, or a cancer? Collectively, the presence of those multiple conditions gives the net clinical picture of a pneumonia. Again, pointing out how easy it is for us to be misled, for us to take a patient who at first blush appears to have pneumonia, but in truth does not. Next slide. Further bringing home this point is if we look at the formal analysis of the predictive value of the clinical signs for pneumonia and compare it to our best gold standard, which is histology, which often turns out to be autopsy, we'll find that none of the clinical signs are specific or sensitive for this condition. So on this slide, what we see are the accuracies of the clinical signs that we use to diagnose ventilator-associated pneumonia. The results on the slide are presented using likelihood ratios. And you'll remember a likelihood ratio is a way of summarizing the diagnostic performance of a test. It says take the pre-test probability of a patient having disease, in this case ventilator-associated pneumonia, and then if the sign is present, take the pre-test odds multiplied by the likelihood ratio, and that'll give you the post-test odds. Now what that means is that if the likelihood ratio is about 1, that means that the presence or absence of that sign doesn't change the odds of the disease being present at all. And lo and behold, look at this, all the clinical signs that we rely upon to diagnose ventilator-associated pneumonia all have likelihood ratios that hug 1, meaning that the presence or absence of fever, abnormal white blood cell count, purulent sputum, crepitations, hypoxemia, does very little to change your confidence as to whether pneumonia is present or absent. The best of the lot over here appears to be the absence of a new infiltrate on the chest X-ray, which has a negative likelihood ratio of around 0.3. So that means that the absence of a new infiltrate makes pneumonia a little bit less likely, but does not rule it out. We say for our likelihood ratio to really change our diagnostic confidence, it has to be above 10 or less than 0.1. And over here we have the negative likelihood ratio for a new infiltrate, only 0.3. Next slide. So it won't surprise you then that if you look at studies of the overall diagnostic accuracy of physicians for ventilator-associated pneumonia, we ain't too hot. We're not too good. So on this slide over here, you'll see that these investigators applied two definitions, a loose definition and a strict definition. The loose definition was a patient who had an infiltrate and at least 2 of an abnormal temperature, white blood cell count, or purulent secretions. You can see over here that the sensitivity for this constellation of signs is around 60%, and the positive predictive value around 55%. When they applied the stricter definition and said, let's require a patient to have an infiltrate and fever and leukocytosis and increased secretions, what did that do to performance? Pause for a moment and just remind yourself, if you were on the wards right now and you were seeing a patient who has a fever, an infiltrate, leukocytosis, purulent secretions, you're not hesitating to call that pneumonia. The docs are not hesitating to prescribe that patient some very broad-spectrum antibiotics. But if we look at the data here comparing the accuracy of that clinical sign relative to autopsy, we can see that it drops the sensitivity down to around 20% and barely budges the positive predictive value to above 60%. In other words, the patient who, in every respect, appears to have pneumonia, the autopsy study tells us that most often they do not have pneumonia, or that we miss pneumonias if we're looking only for those clinical indicators alone. Now, you know well, of course, we're talking about infectious disease over here, so it's important to also look at the microbiology. So we move on to the next slide. Here's the data on the accuracy of BAL cultures, again, relative to autopsy, to histology. The data here are culled from 6 different studies. You can see that while the read from each study is all over the map, collectively, if you pool the performance of each of these studies, what you'll find is that the sensitivity of a positive quantitative BAL culture for the presence of a VAP is only around 60–65%. Likewise, the positive predictive value is only around 65–70%. In other words, microbiology itself, even using a BAL with quantitative culture, is not diagnostic. Now, why is that? Well, of course, you can have 2 different kinds of error. You can have false positives, meaning you say pneumonia is present when pneumonia is not there. And false positives are due to picking up bacteria that live inside the oropharynx or that are colonizing the endotracheal tube. As we know, the endotracheal tube as a piece of plastic is very prone to colonization of bacteria, for biofilm formation that then allows the bacteria to persist and to evade clearance. And so they lead to the generation of false positive cultures that give you a misleading impression of the presence of pneumonia. Conversely, you can get false negatives. You can fail to detect a pneumonia that is present for 2 reasons. One is because of prior exposure to antibiotics that are not enough to eliminate the bacteria, but are enough to prevent them from growing in the laboratory. And as we know, antibiotics are rife inside of our ICUs, and just about everybody is exposed to antibiotics at some point in their ICU stay. And so it's very common that the patient has been exposed to antibiotics before a diagnostic specimen is taken. The other reason you can get a false negative, a failure to detect a pneumonia that really is present, is failure to sample the exact right segment of the lung where the pneumonia lies. So pneumonia itself is a very patchy, heterogeneous kind of disease. It affects one part of the lung but not necessarily another part. And so if you fail to sample the exact right segment of lung, you'll get a false negative. The bottom line is that if you sort of take a step back over here, is that despite applying our best diagnostic acumen for looking for the classical clinical signs the textbook tells us to look for pneumonia, for obtaining imaging, for obtaining even BAL cultures, in the days that we cannot make an accurate call as to who does or who does not have pneumonia when we compare that to a reference standard of autopsy. Now, of course, that puts us in a bind. If we move on to the next slide, we can start to consider together what are some of the implications for prevention. So, next slide. Well, for many years, the classic ventilator bundle that we've all been applying for our patients is the following. Promulgated and really popularized by the Institute for Healthcare Improvement with their 100,000 lives and their 5 million lives campaign, this, I think, still forms the bedrock for what most hospitals do. So, elevate the head of the bed, daily sedative interruptions or spontaneous awakening trials, spontaneous breathing trials, stress ulcer prophylaxis, thromboembolism prophylaxis, and all correxity. If you look at surveys of U.S. hospital practice, just about everyone does the first 3, and I'd say the plurality do the other 3 as well. This is very, very widespread. The problem is that this issue around our limited diagnostic accuracy for ventilator-associated pneumonia creates some biases that also actually apply to prevention studies that we're using to try to choose our prevention practices. So if we move on to the next slide, what we'll see is that there's a fundamental problem over here is that there's a circularity between the way that prevention practices work and the way we define VAP. So the VAP definition, as you saw, is fever, leukocytosis, prion secretion of positive cultures. If you think about the way that the different things we do for prevention work, is they all target one or more of the components of that definition. So oral corexine is going to decrease the amount of positive cultures. Silver-coated endotracheal tubes, same thing. Subglottic secretion drainage is going to decrease the amount of secretions that come out of the patient. Semi-recumbent positioning probably also decrease the amount of secretion. What these intervention practices will do is they'll decrease the number of positive cultures or decrease the amount of secretions that make it appear that there are fewer VAPs, because that's how we're defining them. But we saw together that those diagnostic criteria are neither sensitive nor specific. In other words, you can see a decrease in positive cultures or a decrease in secretions, but it doesn't necessarily mean you prevented pneumonias. Right? The pneumonia can still be there because of the imperfect correlation between those diagnostic signs and the presence or absence of pneumonia. What this means is that if you look at the VAP prevention literature, and you're only looking at a decrease in VAP rate as your sole outcome, you can be sorely misled. So, for example, if we move on to the next slide over here, oral care of chlorhexidine has been reported throughout the literature to be something that significantly lowers VAP rate. I'm showing you over here a meta-analysis that said that across randomized controlled trials, oral care of chlorhexidine is associated with a 28% decrease in the risk of getting a ventilator-associated pneumonia. Highly statistically significant, no worries. That's the kind of finding that went into traditional guidelines and said we should be doing oral care of chlorhexidine for all patients. But I think I've just been trying to persuade you that looking at VAP itself is an unreliable outcome because of its subjectivity, because of its lack of specificity. And if you really want to know if your prevention measure is helping your patients or not, you got to look at the other measures. You got to look at more concrete kind of outcomes that are less subject to subjectivity and variability between observers. And of course, the best outcome of all, the most concrete outcome of all that we have is death. So what does oral care of chlorhexidine do with regard to mortality rates? If we move on to the next slide, some meta-analyses have looked at this. And what they find is that amazingly, shockingly, oral care of chlorhexidine, that thing we're all doing to all our patients, may increase mortality rates. In other words, if you were looking solely at the VAP prevention literature and considering only VAP as your outcome, you would say oral care of chlorhexidine is a great thing. Yet, if you look at these other outcomes, if you say, listen, that VAP outcome itself is not reliable, I've got to look at other stuff like mortality, time on the vent, time in the ICU, hospital length of stay, antibiotic utilization. What you'll find is sometimes the signals go in the wrong direction. So oral care of chlorhexidine may be associated with increased mortality rates. Now, that's another discussion as to why that might be the case. The speculation is that some patients might be aspirating it and causing ARDS. That's a topic for another day. My point here is simply that if you're looking at VAP rates alone as your sole outcome, you can really make some bad calls. Next slide. Stress ulcer prophylaxis, another classic component of our ventilator bundles. A number of studies, not all studies, suggesting that might actually increase the risk for pneumonia. So I think what we're realizing over here is that our traditional VAP bundle is really not quite clearly beneficial for all patients. There are some components that are probably very good, and some components that might be harmful, and some components that are probably neutral. But it's a product of the traditional VAP definition, which arguably, which I'm trying to argue with you, has led us down the garden path. Next slide. The other problem with traditional using VAP as the outcome for quality assessment, for benchmarking hospitals, for trying to work out quality of care for your ventilated population, is that VAP is just one of the many things that can go wrong for a ventilated population. There are many other very serious complications of critical care that can affect a ventilated patient. Why is it that historically speaking, we've only focused our attention upon pneumonia? What about ARDS, pneumothorax, sepsis, pulmonary emboli, pulmonary edema? These are also all morbid complications that can be associated with increased time on the ventilator and worse outcomes for patients. Why don't we pay attention to those as well? So those are some of the problems with using VAP as the outcome measure in trying to design prevention initiatives for patients. Let's switch gears for a moment, next slide, and talk about some of the implications for surveillance. Now, the traditional surveillance definition on our next slide that was published by CDC and used for many, many years to determine our VAP rates is actually made up of the exact same clinical signs that we were just evaluating together and saw had neither perfect correspondence, neither perfect sensitivity nor specificity for the presence or absence of pneumonia. So CDC's traditional VAP surveillance definition required patients to meet 3 different kinds of criteria. They had to have a normal, abnormal chest radiograph, so a new progressive or persistent infiltrate, consolidation or cavitation. They had to have at least one systemic sign, meaning fever or leukocytosis, or a low white blood cell count, or if they're above age 70, altered mental status. And they had to have at least 2 pulmonary signs. Now, the problems here are, first of all, that these signs are the very same ones we analyzed together and found were neither sensitive nor specific. The other thing is that there's a lot of subjectivity that this allows you. Look particularly at the pulmonary signs. So there's things like new onset of purulent sputum, change in the character of sputum, increased respiratory secretions, or increased suction requirements. But it doesn't specify for you exactly how those things are defined. It doesn't say who makes that call. Is it the nurse, the respiratory therapist, The doctor, the infection preventionist, who decides whether the patient has new purulent sputum or an increased amount of secretions? Who makes that call? Increased secretions. How many more milliliters are required to be more secretions? Over what period of time does it have to be sustained? You just get increased secretions for an hour or two, does that count? If the nurse wrote it in the chart, does that make a count? You can appreciate there's a great deal of room over here for discretion, for different infection preventionists who are being very thoughtful, who are trying to do their jobs as rigorously as possible, but to come to very different conclusions to whether there are increased secretions or a change in the character of secretions. And again, if our framework over here that we're thinking about VAP as a potential quality metric, it's very, very disturbing that that different well-meaning people might come to very different conclusions about the patients. In sum, the problem with the old definition was that it was complicated, very labor-intensive to apply. It really required a clinical expert to try to discern those criteria. Yet it was subjective and non-specific, meaning that one could invest a great deal of time, of highly professional effort in trying to acquire VAP rates using that definition, and yet have no sense of the credibility of the end result, that the result itself was reproducible. We've done studies showing that, demonstrating that different infection preventionists come to different conclusions about patients. So this is an old study of ours where we looked at 50 patients with respiratory deterioration who were then independently evaluated by 3 different infection preventionists, all applying the same definition. And you can see that individually, they thought there were anywhere between 11, 15, or 20 VAPs, so a 2-fold variation. Collectively, they only agreed upon 7. And I think what's most striking or disturbing about this is at the end of the day, we don't actually know which of these is right. We don't know if the infection preventionist who called 11 VAPs is right, or the one who called 20 VAPs is right, or none of the above. So high variability without any sense to what the actual right answer is. Next slide. Demonstration of the same issue over here. This was a study in which they took 6 vignettes of patients on ventilators who might have had pneumonia, and they distributed them to the infection control departments in hospitals around the country. They got 43 responses back. And they said to the people who replied, of these 6 case vignettes, how many of them do you think actually had VAP using the CDC definition? And you can see almost equal numbers of respondents felt there were 1, 2, 3, 4, or 5 cases. Meaning again that the distribution of answers was almost random. It was literally sort of all over the map. Next slide. There are other factors that influence the way a hospital's perceived VAP rate. So here's an interesting one. This one actually comes out of England, where they said, what's the impact of our microbiological criteria for VAP? Now, we saw together that quantitative VAL is not a perfect reference standard, that it is neither perfectly sensitive nor specific. They said, how would it affect our VAP rate if we required different kinds of microbiological criteria to confirm a case? And so what you can see laid out over here is the perceived rate of VAPs per 1,000 ventilator days, that's the right axis, depending on whether you allow an endotracheal aspirate with any amount of growth, endotracheal aspirate with a quantitative threshold, or a bronchoalveolar lavage. You can see anywhere between 25 VAPs per 1,000 ventilator days right down to 6, a 4-fold variation. Now, of course, these are the identical patients. You're just applying different kinds of culture techniques to them, but you're getting a 4-fold variation depending on which culture technique you choose. And so how does that allow for any kind of sense of comparability between hospitals? In fact, if you're a little bit cynical, I've actually given you the secret over here as to how you can lower your VAP rates without doing anything to improve patient care. So narrowly interpret subjective clinical signs. Are there more secretions today compared to yesterday? Probably not, right? Narrowly interpret radiographs. Is there pneumonia present? Well, I mean, the radiologist is saying that it could be effusion, it could be alexis, could be pneumonia. It's not definite. I'm not going to call it. Seek consensus between multiple surveyors. Now, we saw when we compared 3 different surveyors looking at 50 patients that individually they found between 11 and 20 cases, but collectively they only agreed on 7. Anytime you try to seek consensus between multiple people, the subset upon whom you can all agree is going to be smaller than the number that we'll find individually. Allow clinicians to veto surveillance determinations. In other words, the infection preventionist looks at the case and says, this patient is a VAP, They send it on to the intensivist to look at. The intensivist says, no, that doesn't meet my clinical sense. The problem with that is that it undermines the very purpose of having surveillance definitions. If you're going to ignore the findings from the surveillance definition, then of course you're going to lose any kind of capacity to have comparability or objectivity either over time or between different institutions. And finally, if you increase the use of quantitative VAL for diagnosis, we saw that the rates of confirmed VAPs with quantitative VAL could be as low as a quarter that of if you allow an endotracheal aspirate with any amount of culture growth. Now, what's I think particularly disturbing about this list over here is that at first blush, many of these things I think would appear to be good things to do. They might appear to be the very kinds of things that your infection prevention program might do to improve the rigor of surveillance. I mean, let's try to be narrow in our interpretations, and let's try to seek consensus, and let's get some clinical input over here. But the net fact over here is that those attempts to achieve rigor will all lead to a decrease in the perceived VAP rate, although you've done nothing itself to actually change patient care. And of course, that fundamentally undermines, in my opinion, the credibility of the old definition. So, next slide. If you look at U.S. national VAP rates using the old definition, this is what we were seeing throughout the first decade of the century over here, dramatic decreases being reported by hospitals in their VAP rates to CDC. You can see over here the drop in VAP rates in surgical ICUs and medical ICUs, VAP rates coming down to almost zero. And the big question mark when we looked at these data was, is the decrease in VAP rates because hospitals are providing better care? Or is it because infection preventionists, knowingly or unknowingly, are being stricter about applying those very subjective, willy-nilly surveillance criteria, and there's a perceived decrease in VAP rates, but it's not a true decrease? And the problem was we did not know. We don't know which of those it was. Was it better care or was it surveillance artifact? When you reach that point, then you say the definition has failed me. It's failed to allow us to understand if we're doing a better job or not. And the clue that, in fact, surveillance artifact was certainly part of the story came from a recent paper in JAMA where they took CMS audits. So it turns out CMS audits some fraction of patients that hospitals bill CMS about, and they had their own independent pneumonia definition. And when they applied their own independent definition, so now CMS making the call as opposed to the hospitals themselves, they found that over the same period, 2005 to 2013, VAP rates in their sample hospitals was absolutely rock stable. No difference in or change in their VAP rate. Again, undermining the credibility of the perceived decrease in VAP rates being reported by hospitals to CDC. And just be clear, I'm not saying that hospitals here were faking or gaming or trying to manipulate the system. I don't think that's the case at all. I think well-meaning people were simply trying to be as rigorous as possible as their programs became more and more under the spotlight. And as they became more rigorous, that inevitably led to a decrease in VAP rates because of the subjectivity and the looseness of the VAP definition. Now, where does this leave hospitals? Next slide. We have inherent tension. We have those who say we need to publicly report VAP rates to catalyze improve quality of care and save lives. And those say, well, hang on a second here. That definition of VAP is ambiguous. It's hard to implement. It's open to be gamed. The results aren't credible. And so, faced with that dilemma, CDC in 2011 called together representatives from stakeholder societies, next slide, to say, do something about this. Come up with a different approach for us. So here are some of the societies that were present. So AARC was certainly there, but as well the American Thoracic Society, Critical Care Medicine, Nursing Society, Infection Prevention Control, the Infectious Disease Community, Public Health, and CDC said to this group of people, what can we do to overcome this issue? Next slide. And what this group came up with were the VAE definitions. So that was the group that created this VAE concept. Next slide. And what they said is we need to take an alternative approach to surveillance. If the fundamental problem is that as clinicians, at the bedside, we can't tell with any kind of certainty who does or does not have pneumonia, then that should not be the focus of surveillance. How about instead, we broaden the focus of surveillance from pneumonia alone to the syndrome of ventilator complications in general. And the advantage of doing so is that, first of all, it's a more accurate description of what we can reliably tell through surveillance at the bedside. Right? We can't tell with certainty who has pneumonia, who does not, but we are better at getting a read on who's doing better and who's doing worse. The other big advantage of this conceptual shift from pneumonia alone to complications in general is that it emphasizes the importance of preventing all complications of mechanical ventilation, not just pneumonia. And the moment we let go of the idea that we can find pneumonia itself and are looking for respiratory deterioration in general, it allows us to substantially simplify the definition and, in fact, even enable the electronic collection of variables in the application of the definition through computers, which, of course, offers tremendous advantages in terms of objectivity and efficiency. Next slide. So that was the genesis of the ventilator-associated event concept. The precise definition over here is that a ventilator-associated event is defined by changes in ventilator parameters, in particular the PEEP and the FiO2. And the idea over here is that you conceptually speaking, what you're looking for a patient who has stable PEEP and FiO2 for at least a couple of days, and then has sustained increase in either their PEEP or their FiO2 that, again, lasts for at least a couple of days. And as you know, when we put a patient on a ventilator, our first mission is to get that patient off the ventilator as soon as they're strong enough to be able to tolerate that. And classically, we do so after the patient gets over their acute illness by trying to wean down the ventilator settings. And so if you see a pattern where ventilator settings were stable, 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 or down, 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 and suddenly went up and stayed up for at least a couple of days, you know something's gone wrong. That was not the expected plan for that patient. We tried to continue to decrease the settings until we can get the patient off the ventilator. And over here, we saw the opposite pattern. And that essentially is all that a VAE is. It's a trajectory change in ventilator settings that was unexpected. And so in this particular example over here, the patient began with a PEEP of 10 and FiO2 of 100, came down to 5 and 50, then 5 and 40. But on January the 5th, as you can see, the patient's PEEP was increased to 8. It stayed up for at least a couple of days, and that meets the VAE criteria of a jump in PEEP by 3 or a jump in FiO2 by at least 20. Now, I can't tell you what went wrong with that patient. I don't know if that patient had pneumonia, had a pneumothorax, had sepsis elsewhere, got atelectasis, fluid overloaded, who knows? But I can tell you with fair certainty that maybe something went wrong with that patient. Now, there are subcategories of VAEs, next slide, that attempt to discern the fraction of those VAEs that might be due to infection and the fraction of those that might be due to pneumonia. And they add on additional criteria, and IVAC adds on criteria for temperature and white blood cell count and antibiotic utilization. Possible pneumonia also looks at the respiratory secretions for either quantitative culture or the presence of neutrophils suggesting purulence. So there are those additional criteria that can give you the subset that might be infection-related and that might be pneumonia-related. We shouldn't fool ourselves to say that just because these new criteria are objective, that they're any more specific than the original clinical criteria for VAP. They're not more specific. We have nothing to suggest that's the case. What they are is more objective. What they are is more efficient. So we've gained in the objectivity and efficiency side, but we haven't solved the problem of sensitivity or specificity, just so we're very clear with one another. Next slide. Now, the beauty of this system based upon FiO2 and PEEP, temperature, white blood cell count, antibiotic exposures, and cultures, and gram stain, is that all that data is objective and electronic. And what that means is that a computer, a calculator, can do the surveillance for us. So what I'm showing you on this slide over here is CDC's NHSN VAE calculator, which allows people to do exactly that. For an individual patient, you can toss into this calculator the PEEP, the FiO2, temperature, white blood cell count, the antibiotic exposures, and the calculator will spit out for you whether the patient has a VAE, an IVAC, or a PVAP, and it'll tell you why it does or does not meet one of those criteria. So it's a very nice education tool. The pain about this tool is that it only allows you to assess one patient at a time. Okay, so it's very nice for teaching and for confirmation, but it's not very useful for a hospital like mine, which has 100 ICU beds, of whom 60% might be on a ventilator at any given time. It's not a very efficient tool to be able to do surveillance. And so what a number of hospitals have come up with are electronic reports that actually could do VAE surveillance for the entire population. So next slide. Over here is just a selection of papers from literature of hospitals reporting their experience coming up with automated systems. And we're seeing more and more of this taking place, and commercial infection surveillance software such as Theradoc, such as Epic's Bugsy module, and others now have this as a feature where they can automate surveillance. And that, of course, has tremendous potential benefits for an infection control program, because the infection preventionists, instead of sitting in the basement looking at a computer screen and trying to work out who does not have VAP can now be on the wards actually working on prevention initiatives as opposed to surveillance. It also takes away, of course, the arguments between infection preventionists and clinicians about who does or does not have VAP, because now it's an objective definition. So there's one final answer that we all can agree upon because it just meets the criteria. Again, we might argue as to whether that patient has pneumonia or not. There's plenty of room for argument on that front. But we've shifted the locus of the argument from the application of the definition to really the cause of the event. Next slide. Now, VAE has now been around for about 5 years, and we have an accumulating body of about 100 papers now looking at different aspects of VAE epidemiology, risk factors, outcomes, and prevention. And I'll share with you a few snapshots from that. So this slide over here looks at the attributable mortality of VAE versus VAP, and pretty consistently across studies, VAE is really bad for you. It's associated with a doubling of the risk of dying compared to a similar patient without a VAE. In most cases, VAE is more morbid than a traditionally defined VAP, with a few occasional exceptions. Next slide. Now, there also are a number of studies now looking at the overlap between VAE versus VAP. And here's one representative study from the Canadian Clinical Care Trials Group, where they compared VAE surveillance to VAP surveillance, and what they found is that while the VAE and VAP rates were pretty similar across the population, they dug down the cases themselves. What they found is that the amount of overlap was limited. So you can see over here they only agreed on 39 cases, but there were 100 additional VAE patients without VAP, and conversely 109 VAP patients without VAE. Now, the VAE patients who do not have VAP, that's no surprise, right? We expected that, because we said a particular mission of VAE was to expand the purpose of surveillance, to say we want to capture other things that cause problems. We want to capture the ARDS, the pulmonary edema, the atelectasis, so on and so forth. So that's no surprise to us. People are more bothered by the other side of the equation over here, the VAP patients who do not meet VAE criteria. The positive predictive value of VAE for VAP is around 30%, the sensitivity might be around 45%. In other words, VAE misses about half, maybe even more, of patients who have a traditionally defined VAP. Why is that? Well, the answer, if you think about it, has to be because those patients did not have stable and then increased ventilator settings. Their pneumonia was not associated with a sustained increase in ventilator settings. Now, if you take a step back, you've got to wonder for a moment, what's the clinical significance of a pneumonia that does not impose increased respiratory burden upon the patient, that doesn't require any more support from the ventilator? I think what it says to me is that it's either a mild pneumonia or it's not a pneumonia at all. It's one of these many mimicking conditions that we all saw together, be it tracheobronchitis or colonization of the respiratory tract or pulmonary edema, so on and so forth. So what VAE, in essence, is doing is focusing on the subset of pneumonias that are severe enough to require an increase in ventilator settings. And that's a classic approach in surveillance, to try to focus on the subset of patients with the most unambiguous and severe conditions. In surgical site infection surveillance, for example, we focus our attention on deep surgical site infections, not just a little bit of redness of the incision. Next slide. The take-home message over here is that VAE is not VAP, and that's intentional, it's by design, and it has important implications for how we think about prevention. Next slide. Now, if VAE is not VAP, what is it? What actually is the clinical event that kicks off that VAE? Now, there's also a stack of studies looking at the same question, but they all have the same conclusion. So if we look at the slide over here titled Qualitative Analysis of 103 VAEs, it'll give you the take-home message from those studies, which is that the things that trigger that increase in ventilator settings that leads to a VAE really caused by 4 different things: pneumonia itself, pulmonary edema, atelectasis, and ARDS. Those 4 things account for the vast majority of VAE. Next slide. So again, VAE equals not just VAP, but VAP plus excess fluids, ARDS, and atelectasis. Next slide. So if we want to decrease our hospital's VAE rate, how are we going to get there? And I think we've now been armed with the key information. Next slide. Reflecting those etiologies of VAEs, here are what the literature is currently telling us about the risk factors for VAEs, culled from a number of different studies. So sedation, particularly with benzodiazepines and in some cases propofol, positive fluid balance, high tidal volumes, high inspiratory driving pressures, blood transfusions, oral care chlorhexidine, stress ulcer prophylaxis, patient transport, gastric retention, reintubation, and neuromuscular blockade. So we now have, I think, the essential information to know how to prevent VAEs. I'd say you take into account what we know what causes VAEs, these risk factors, and the first principle. The first principle is that if you get the patient off a ventilator or you avoid the ventilator, you're not going to have a VAE. Next slide. So here then, I think, are the key strategies for preventing VAEs. You got to decrease exposure to the ventilator, so either avoid intubation or shorten the duration of intubation, and you have to put into place the prevention practices that target those risk factors and the primary conditions that we know cause VAEs. Next slide. And on my reader literature, the things that we know from randomized controlled trials that do one of these two things, they either decrease time on the ventilator or they target one of the primary conditions that cause VAEs is this. It's minimize sedation, use paired daily SATs and SBTs to get the patient off the ventilator as soon as possible, mobilize your patients, minimize the amount of fluids you give to your patients, particularly in the post-resuscitation phase, and minimize your blood transfusions and probably low tidal volume ventilation. Next slide. And the good thing is that none of this is surprising, none of this is controversial. This is the exact same thing that everybody else is telling us to do for our patients, right? If you look at ABCDEF, this is what it says: choosing wisely, the PAD guidelines, surviving sepsis, the VAP prevention guidelines. They all basically include a similar collection of recommendations. And so VAE prevention is very well aligned with everything else that we're being told to do for this population. Next slide. Now we do have some data again on the association between ventilator compliance by component and VAEs, and it turns out that the best thing you can do to reduce VAEs is spontaneous breathing trials. And that's, of course, because the spontaneous breathing trial is designed to find that first moment when your patient can fly without a ventilator. In other words, it's a very potent strategy to get your patient off the ventilator as soon as it's safe for them to tolerate doing so. So that, in most studies, has been found to be the one thing that really gets patients off the ventilator as soon as possible and minimizes their VAEs. Next slide. And in fact, minimizing sedation and spontaneous breathing trials have also been associated with decreased mortality, even in particular bundle type studies, as well as in prospective randomized controlled trials and in intervention collaborative. Next slide. I'll share with you one collaborative that looked at VAE as the outcome. This was the CDC Prevention Epicenter's Wake Up and Breathe study, which was a care improvement collaborative with 12 ICUs, took place over a year and a half, and the goal was to prevent VAEs through early liberation from mechanical ventilation by a pair of daily SATs and SBTs. Next slide. And over the course of that year and a half, they saw a 40% increase in SBTs and a 100% increase in use of SATs. Next slide. And that was associated with a 37% decrease in VAEs and a 65% decrease in infection-related ventilator-associated complications. Next slide. Bringing home that we're not just massaging the numbers around VAE or VAP, but are actually seeing tangible improvements for patients and their outcomes. This study was also associated with a shaving of 3 days of the average duration of ICU stay and 2.5 days of the time on the vent. Next slide. Another study in showing the importance of fluid as both a risk factor for VAEs and as a strategy to be able to decrease VAEs is this randomized controlled trial. It took patients during the weaning phase of mechanical ventilation and randomized them to a depletive fluid management strategy versus usual care. Depletive fluid management was accomplished by checking BNP levels, which give you some sense of the amount of stretch inside the heart, which is a proxy for the amount of fluid on the body. And when it was high, the goal was to minimize the amount of fluids in and increase the amount of diuretics to get fluid out. And patients who were randomized to daily BNP levels had more diuretics and more negative fluid balance, which led to about a 2-day decrease in the time to extubation and a 50% decrease in VAEs, again, bringing home the importance of fluid as a cause of VAEs and as a prevention strategy. There are also large statewide initiatives that have taken some of these bundle components to prevent VAE. So over here, this was reported in Critical Care Medicine a year or two ago. 56 ICUs in Maryland and Pennsylvania implemented a VAE prevention bundle, and again, that was associated again with a 37% decrease in the VAE rate. So there's no debate over here. VAEs are clearly preventable. We know what to do to prevent them. We need to adopt the same best practices that everyone else is telling us to do for this population. And with that, you can also realize concrete gains and objective outcomes. Next slide. Taking a step back over here, I think that the introduction of VAE really is a patient safety opportunity because it can broaden awareness, it gives you a fuller picture of the range of serious complications in your ventilated population. If you know about it, that then is the spark, the catalyst to prevention, and we can see that a significant fraction of VAEs are preventable through well-accepted best practices. And finally, we now have a more objective metric to reflect and inform our progress. We don't have to worry if we see a decrease in VAE rates that it's due to the surveillance bias of the old VAP definition, the subjectivity of surveillance. We can feel more confident now that we're actually seeing a true decrease in serious disease rates. So last slide, summary. VAP is a poor metric for benchmarking and quality improvement because the diagnosis is subjective and inaccurate. There's high inter-observed variability, and therefore it's a poor guide to selecting prevention practices to improve patient outcomes. Thus, CDC created ventilator-associated event definitions to enhance objectivity, automation, and expand prevention efforts, and something that is suitable for automated surveillance. One can lower VAE rates and improve outcomes by implementing strategies to reduce the duration of mechanical ventilation and to prevent the primary conditions associated with VAEs, which again is pneumonia, ARDS, Alexis edema, minimize sedation, pair your SATs and SVTs, mobilize your patients, minimize fluids, and minimize blood transfusions. Okay, thank you.
Well, thank you very much, Mike. That was great, and I'm sure that everyone on the program has learned quite a lot. We do have time for a few questions, so I might read off a few of these and you can address them. There still, I think, is some confusion among respiratory therapists and others about exactly how we determine if a VAE does or does not exist. So let me read this question, which I think sort of summarizes what I just said. This participant writes, I agree with the thought process of VAE, but the timeline does not always work. It appears you have a significant time on certain ventilator settings over 2 days. It really isn't over 48 hours. It's only the lowest PEEP over 2 calendar days. This could and does occur over a very short time frame at times, sometimes less than 6 hours. So maybe you could go over in just a little bit more detail about how a VAE is defined and maybe specifically the issues of a sustained period of ventilator settings followed by a sustained increase in PEEP or FiO2.
Okay, yeah, sure. Thank you for that question. So I think you're pointing out an important tension over here. And just to elaborate upon your question over here, what if the patient goes onto the ventilator at 11 p.m. And they're 25 hours later, at 1 a.m. 2 days later, they have a jump in their ventilator settings. Is it really fair to say that patient had stability if they were really only at their baseline ventilator settings for 25, 26 hours, as opposed to the intent of 2 calendar days? So you're right. That's a weakness of the definition. That's a compromise that CDC made in order to make the definitions easier to apply for hospitals that don't have electronic systems and that have to do surveillance manually. You could imagine how it would be a real pain for some poor person with a pencil and a pad of paper to have to calculate 48-hour intervals for ventilator settings. And so CDC said, okay, to make things simpler for hospitals that don't have electronic systems, we'll go with a per calendar day approach. And that CDC has made that same decision, used that same strategy for all the other events that they conduct surveillance for centralized associated bloodstream infections, surgical site infections, so on and so forth. They use that same calendar day rule rather than actual hours of exposure. So I think that it's a compromise. It does weaken the definitions. On the other hand, it makes it possible for smaller centers without automated systems to do surveillance. You can imagine, and I hope, that there'll be a day when hospitals have sophisticated enough electronic systems that all hospitals will be able to automate their VAE surveillance. And at that point, I think it will be possible to switch to 48-hour rules rather than calendar day rules. So I think that's an aspirational goal. We're not there yet, but hopefully we'll get there at some point.
Okay, I'll ask just one other question, and we're going to be at our 1 hour time. So you certainly struck a nerve by pointing out that with chlorhexidine, we can lower our VAP rates, but maybe increase our mortality rates. So a question that came in is, if we are not to use chlorhexidine, is there another agent that we should use for oral care, or just use nothing at all other than, say, clearing the upper airway with suctioning and so forth?
Yeah, that's $1 million question. I think that's one we all want to know the answer to. So let me say this, which is that oral care chlorhexidine is the best studied oral antiseptic that we have out there. There are data on some other alternatives like providone iodine, like isoganon, antibiotic slurries, what have you, but none have been as well studied as chlorhexidine. Some of the other antiseptics have shown safety signals as well. So providone iodine, for example, is associated with increased risk of ARDS. So the sad truth is we actually don't know if other alternatives are safe or not. So I think what we're currently recommending is, first of all, that oral care should still go on. Oral care still is a good thing, but we just leave out the chlorhexidine component of it and use sterile water instead. So we'd still do mechanical toothbrushing, we'd still do swabbing out the mouth, we'd use sterile water as opposed to an antiseptic. And that's simply because we don't know if another antiseptic is safe or not. Again, the speculation with chlorhexidine is that the reason it might increase mortality is that some patients are aspirating it and leading to ARDS. And you could imagine how that same problem might also be true of other antiseptics, which also might have caustic properties for lung tissue. And so, if the base problem is simply is aspiration, you could imagine how anything inside the mouth, other than perhaps a small amount of sterile water, will have that problem. So this is a real area of need for us.
So upper airway cleaning is good. Upper airway disinfection may be not as good.
Yeah, I mean, in principle, I think it should be good. We just don't know what the right product is to use. And it could also be that different kinds of formulations, that a gel formulation, for example, might be safer. But we don't have the data to back that up. So if any sort of innovators out there, this is an area I think where we desperately need an alternative.
Well, we reached 1 hour, we're actually a little bit after an hour, so I think I need to wrap it up here. Mike, thank you for joining us today. It was a great presentation. And thank you to all of those of you who joined us as well. Join us next Tuesday, June 4th, as the AARC Summer Ventilation Series continues with a presentation on optimizing lung protection in the NICU with Rob DeBlasi. The Summer Ventilation Series continues on June 26th with a discussion of the June 2018 Non-Invasive Respiratory Support Respiratory Care Journal Conference with John Davies. So once again, thank you for joining us today, and have a great day.
All right, and one last thing before everyone closes out. Thank you to Michael for an excellent presentation, and also to all of our wonderful attendees for joining us and for your participation today. As a reminder, if you are a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on submitting for credit. This does conclude today's presentation, but to submit for credit, please click on your credit submission tab. Once finished, you may simply exit out of your browser windows. We do hope that you have a wonderful afternoon. Thanks for joining us.